Hi, my name is Holly. I'm an adult geriatric nurse practitioner with Destiny Hospice and Palliative Care, and I'm also a certified hospice and palliative care nurse. So just a little bit of background. I did start out as a caregiver in the 80s, and I was a caregiver, then I went and took CNA classes, CHHA, South Dakota State University to get my bachelor's in nursing, and then the NP curriculum. So I've been in your shoes. I appreciate the challenges involved in caregiving, and I want to first of all thank you for choosing this profession because it's very needed. It's going to be more and more necessary as my generation continues to age and the next generation comes up. So thank you for doing this, and I know how difficult it can be, but I also know it can be rewarding. So that being said, let's go on to the presentation. This is going to be about hospice generally and Alzheimer's specifically. I get questions from caregivers in particular about how to figure out if somebody needs to be assessed for a higher level of care, how to know if they have Alzheimer's, how to know if their Alzheimer's is progressing to the point where they need to be reassessed, and to just kind of how to deal with things on that basis. So Alzheimer's disease, we call it dementia or Alzheimer's. Alzheimer's is just one piece of the dementia puzzle. There are many various types of dementia. But Alzheimer's is one that clogs up and destroys neural pathways. When you look at a brain, somebody who's deceased who had Alzheimer's disease, you can see the tangles and the plaques in the brain, and that's how they absolutely determine it was Alzheimer's. And so it's a disease of exclusion. If there are not other chronic diseases that could be contributing to a mental decline, then you can do some tests and figure out that, yeah, this looks like that, like Alzheimer's disease. So how do you know when it's time to look at a higher level of care, and how do you know what's causing the cognitive decline? Well, a doctor will do some tests, and if you have 2 or 3 cognitive areas in decline, yeah, it's probably Alzheimer's. Disorientation, disorganization, you can read that. I don't have to read all those words. The 2 most important ones in my mind that indicate it's time to take a closer look is the disorientation and the loss of functionality. The other 3 things can be come and go. They can be, intermittent. They can be parts of some kind of a different process. But when you see the disorientation and the inability to care for oneself, then that kind of says, let's have somebody come in and take a look and see if we need a little something more than what we're getting right now. And there are mental skills tests that a doctor can administer to get an idea of what's going on. So while there is no specific test that says this is absolutely Alzheimer's, you can look at how somebody's acting, look at the difference in how they were acting, 6 months ago, and then you do the tests and you can pretty much determine, yeah, this looks like what it is. It's accurate 85 to 90% of the time. There is a PET scan that can get you closer to 100% accuracy, but it's probably kind of doubtful that insurance will pay for that PET scan just to diagnose Alzheimer's, because that's how insurance companies are. So there are 7 stages to Alzheimer's disease. 1 is normal. That's what we hope we all are. You know who you are, you can take care of yourself on a daily basis, you can take care of all the little various things that need to be taken care of during the day as far as, having clean clothes and bathing and paying bills, and you know what day it is, you kind of know what season it is, even though the days and the dates often, go out of our minds even if we're normal. You have fairly good judgment or reasonable judgment, and you can communicate, tell people what you need to tell them and they understand, and once again, the daily activities. Stage 2 is normal aged forgetfulness, and this It says ages 65 and older, but I'm telling you, the busier we get, the more I see this in lots of people who are not 65 years old. Lapses in memory. Family and friends might not notice it because it's not consistent. And the cognitive problems, like not being able to figure addition or subtraction or something like that. Not something that necessarily is going to be noticed at a medical exam, just because they're so short and you have to be so quick and so specific that unless the doctor knows somebody really well, they're probably not going to detect any issue that needs to be addressed. Mild cognitive impairment. Things become a little more obvious. Communication skills, behavior, little changes. You might progress to mild Alzheimer's from this point, might just stay here for a while. People at work might notice a difference in social gatherings, you know, family gatherings. Oh, God, grandma looks, you know, she's acting weird. What's going on? New material. Now, honestly, I'll tell you, after a certain age, new material is an issue unless you can connect it to things you already know or situations you've been in. So just not being able to memorize things immediately is not saying that you have Alzheimer's disease, but and keep in mind that this is a combination of signs that we look at to determine Alzheimer's. One of these things is not going to put you in an Alzheimer's diagnosis. Increasing frequency, so if it's a change, decline in organizational skills, repeating questions, and the evident anxiety, I think that probably is because when you're not quite functioning the way you're used to functioning, you know something's wrong, you don't know what's wrong, you don't know what to do about it, but it causes you anxiety because you're worried, oh my God, am I losing my mind? Stage 4, mild Alzheimer's. Things are more obvious now. Neurology can diagnose it pretty confidently. Can't remember maybe sometimes personal details, like something about your life that normally you'd be able to bring right up. Some confusion, putting the towel in the fridge. I don't think that's a very good example because I know people in their 30s who put the milk on top of the refrigerator and put the cereal box in the refrigerator. So once again, remember, one of these things, or two even of these things, does not indicate dementia or Alzheimer's. The checkbook, social withdrawal. Now the social withdrawal and the moodiness, it seems like it's probably as a result of the foregoing issues, because if you're not comfortable in social situations, you can't remember people, you can't remember facts, you're going to be less apt to want to interact socially because you don't want to be judged. So the social withdrawal happens, and then of course as a result of that, it's the moodiness and maybe some depression. Stage 5 is moderate. This is when people can no longer live by themselves. It might be intermittent, you know, you're there 4 hours a day or something like that, but chances are it's going to be more often because wandering starts at this point. And when somebody is in stage 5, if they wander away from the house and somebody tries to get them back home, they're not going to remember their address, they might not remember their name, their phone number, you know, various things that just make it really dangerous to not have some kind of supervision. Decreased personal hygiene skills. I just took a shower this morning. Well, no, actually it was last week, but let's try it again. And more sleeping. Stage 6. This can be the hardest one because this is when the personality changes come into play, maybe not remembering loved ones or caregivers, well, especially loved ones, you know, relatives. More withdrawal from surroundings, wandering continues, not only forgetting recent events, but not even being aware that they're happening. And that's why the family gets upset during this time if they don't understand the disease, because they're no longer recognized by someone that they've known all their lives. And my cat wants to be in the film. Next, stage 6, continuing. Now, Sundowning is something that everybody's probably heard of. Anybody who's worked with the elderly has heard of it. And we know it's a thing, we know it exists, we know it happens, we know how to identify it, but we don't know what causes it. There are various ideas about what could cause it, but we don't have anything specific that everybody says, yeah, that's what causes it. So that's something that if you feel like researching, research into the tests or look into the research involving sundowning, and it's pretty interesting. Bathroom management. Somebody can't clean up properly after they have a bowel movement, not getting there quite soon enough, starting to have accidents. Suspicion, paranoia. Try to give somebody medication, they think they're being poisoned. Trying to make them eat certain foods, they think they're being poisoned. They can't find something, they assume that you've taken it or somebody else has taken it, and that's just part of the disease process as well. Shadowing is when just kind of follow you around because not sure what else to do, confused, so it's easy just to find somebody you recognize, follow them around. Repetitive and compulsive behavior, this is the pill rolling, repeating phrases over and over, telling the same stories over and over, which is once again not a sign of Alzheimer's on its own because a lot of people do that, but it's part of a whole group of signs that you'll see. Stage 7, severe, that's when somebody may be hospice appropriate. Now, if they've had a decline, and they're not quite to stage 7, absolutely. If you have somebody you want to call in to evaluate them to see where they are, when they might be appropriate for hospice or some higher level of care, call them in before that. But once somebody gets to this point, chances are we can put them on hospice, and that'll be extra help for the caregiver as well as for the patient. This is the final stage. They can maybe understand what you're talking about or understand a conversation, but not able to form the words to respond. Maybe repeat automatic phrases, they call it, or just say words, but not anything that's really cohesive and really related to the conversation. And it's going to be limited, maybe a few words here and there, but not really evidence of the ability to think out a response to a question or to communicate really well enough to present new ideas, that sort of thing. Physical symptoms begin to deteriorate. Now the reason, part of the reason physical symptoms begin to deteriorate is because they're going to be less active, deconditioning, they're going to be sitting in the recliner a lot, probably taking naps a lot during the day. The coordination may not be able to sit up without being in a recliner or something with some chair with arms on the side. If you put them up in like a dining chair, they might kind of lean over. That's later on. That's not the beginning of stage 7. And then swallowing becomes difficult and choking is a risk. So when we get to stage 7, so these are the pieces of stage 7 on Alzheimer's disease. The ability to speak, limited to 1 to 5 words a day, or it can be just nonsense words, just spewing words that don't really go together or make sense, or it can be repetitive phrases. That's also something that indicates there's not really a thought process going on with the response, and they're not really thinking through what they're saying. It's just things that are coming out of their mouth. And then next is all intelligible vocabulary loss. That can be the same thing, just random words, or babbling, just making sounds but not really being able to form words. 7C is either they need to have their hand or their arm, their pants held, or use a walker. 7D, can't sit up in, say, for example, a dining chair. You have to either be propped up by pillows or have armrests on the chair. 7E, no longer able to smile. 7F, can't hold your head up. Obviously, those are very... So what are the other possibilities for changes in personality or changes in mentation that happen kind of suddenly? There are other issues besides Alzheimer's or dementia that can cause that. One is infection, for example, a UTI. One of the first things you think about, somebody debilitated over the age of 70 or so, they start acting differently. Ooh, maybe they have a urinary tract infection because Sometimes they don't have any changes in their urine, they don't have a fever, but they can just have a behavior change or be agitated. And so we want to test for a urinary tract infection. There are other infections too. Anything that, if something gets into your blood and causes sepsis, that can absolutely change the way you interact on a daily basis. Deficiencies in malnutrition. If somebody's eating less or they only like to eat one food or something like that, then they're not going to be getting all the nutrition they need. Malnutrition and vitamin deficiencies can change behavior and mentation. Dehydration and fluid imbalance. This often goes along with UTIs, because if somebody is dehydrated, they are more apt to be getting a urinary tract infection because they're not urinating frequently enough and not cleansing out the urinary tract. So those are all things that can cause confusion or restlessness or combativeness. There is more than one kind of dementia. Alzheimer's disease is one that we hear about all the time. Vascular dementia is probably the next most common one. If somebody has had strokes, heart attacks, heart surgeries, has diabetes, and so they have problems with their veins and arteries, their circulation, that can cause vascular dementia, and that's one of the diagnoses that we can use if it gets to a certain point for hospice. Dementia with Lewy bodies, you probably heard about that since Robin Williams died, because that's what he had. And probably the most marked thing about that, to differentiate it from other types of dementia, is as opposed to memory, it often manifests as Parkinson-like symptoms, and it may be related to Parkinson's. Hunched posture, rigid muscles, shuffling walk, trouble initiating movement. People freeze and they just can't seem to make that next movement or take that next step. And then hallucinations. That's another something that happens in that particular type of dementia. These other kinds of dementias, you might want to, if you're interested, research these various kinds of dementias. The ones I talked about are the ones that you're most likely to see, but the others are quite interesting too if you want to look into those. When to think about hospice? Other than dementia or Alzheimer's disease or vascular dementia, whatever you want to call it, there are just little signs that you can see with people that indicate there's a decline and maybe they need a higher level of care. Confusion, weakness, increased sleeping, walking without assistance, ability to interact verbally, and needing assistance with 3 or more ADLs. ADLs are activities of daily living, include such things as dressing yourself, feeding yourself, toileting yourself, being able to get up out of a chair by yourself and get to another place. So if people need help with all those things they do on a daily basis, then it could be a good time to evaluate them for a higher level of care. So there are several diagnoses that people think of when they think of hospice. Cancer, obviously, is one of them. If somebody's not going to go through treatment anymore, they've been doing chemo or radiation, that's over, it hasn't worked, surgery, whatever. If none of the curative things have worked and they're not going to do them anymore, and if the cancer has moved from its origin to a different place. Say, for example, somebody has breast cancer. Well, that's in one place, but maybe it's in the lymph nodes. Once it gets in the lymph nodes, it can go anywhere it wants. So that's considered a metastasis because it's moved from the initial place it started to someplace else. A lot of times if somebody has lung cancer with, bone mets, you'll hear that term, or brain mets, that means the cancer has moved to another place. It's the same cancer. It's not a new kind of cancer. It's just traveled through the body, the circulatory system or the lymph system, and started growing in a new place. Liver cirrhosis. The first thing you'll notice about hospice-appropriate liver cirrhosis is ascites, probably. People's bellies get big and kind of hard, and you can tell that they're full of fluid. It's not in the intestines, it's actually in the abdominal cavity. And then there are various lab tests we can do to determine if it's at the point of needing hospice. Heart failure, if somebody has had heart attacks or heart surgeries, valve replacements. They have chest pain, shortness of breath, even at rest, but especially when they try to do any kind of activity. If they're taking multiple cardiac medications and the surgery is not an option, then we can evaluate for hospice. COPD, a lot of people don't understand, and I want to explain this to you. COPD is the umbrella over various respiratory issues. So if somebody has pulmonary fibrosis or emphysema or chronic bronchitis, that's all COPD. Those are all issues with respiration and the ability to breathe, the function of your lungs, the function of all the little things that go into taking a breath, and being able to have the gas exchange that gets the oxygen where it needs to be. All those are COPD, and if it's to a certain point, they are hospice appropriate, and it's usually oxygen dependence, recurring respiratory infections, using inhalers all the time or breathing treatments, and just not being able to do their normal activities without getting out of breath and having to rest. Stroke, that's kind of with ALS. It's a neurological thing because the result, even though a stroke might be caused by cardiovascular issues, the manifestation is going to be can't swallow, can't use one side of your body, very weak. It's going to be neurological manifestations. So weight loss is a big thing. With renal failure, if somebody's taking dialysis and they just say, I'm done, I can't do it anymore, we can evaluate for hospice, and there are various lab values we look at as well. HIV/AIDS, lab values are a big deal on that, but if somebody has been taking antiretrovirals for many years, which is the usual occurrence when you have HIV, you can do that for a long time and stay stable. But if for some reason, because of confusion or debility or just not wanting to do it anymore, they stop taking those medications, then the disease will most likely advance. A lot of different lab values will change, and we can evaluate those, and that might be some time to think about hospice. ALS, once again, that's a neurological dealio. And the speech is affected, shortness of breath because the muscles that you use to breathe are affected, swallowing is affected, and once again, ALS is something where your brain is fine, it's working, doing all it's supposed to do, but all the neurons and the pathways that it uses to communicate with the rest of your body are slowly deteriorating. So that communication is no longer possible. So the brain is okay, but maybe can't talk, can't breathe. Some people go on respirators, some people don't. Can't swallow, some people go on feeding tubes, some people don't. It just depends on the situation. So what is your job when a patient is on hospice? I like to use this slide a lot on facilities, but even with you working in somebody's home, you just keep doing what you always have done. You might have different pathways when you need outside help, but you take care of the person the way you normally would, even if they were not on hospice. In fact, if they have a fatal diagnosis, they might need more listening, more attention, because maybe it was a surprise and they're depressed and they just want some understanding. So new orders, if you have a problem with one of the medications or you need an order for whatever, you go to the hospice. You call the hospice company. You don't call the PCP anymore as you normally would, or you tell your supervisor and the supervisor calls the PCP. You might call your supervisor and say, this is what's going on, and they'll just say, call hospice and we'll deal with it. We'll send a nurse or we'll have somebody on the phone who can address whatever issue it is that you have. We'll supply some of the medications if it's specifically related to the hospice diagnosis. And then any medications that are not related to the hospice diagnosis, those continue to be filled as normal through the insurance company. We can give some supplies. We won't be able to supply everything you could possibly need to take care of this person for the rest of their life. But, we'll give you some underwear, some diapers, some chucks, things like that. We can add to what is already there, but we can't supply everything for everybody. The medical director takes over responsibility. The PCP can choose, the primary care physician can choose to follow that patient and be involved in that person's care, but that's not the norm. Normally, primary care physicians are so busy during the day, they don't want to be called at 2 o'clock in the morning on a weekend, so they just have the medical director take care of all those types of orders and issues, and then we just update them however often they would like us to update them. Any changes of condition, call us. If the patient dies, call us. Just remember, this is still your person, so you do whatever you would do if we were not there, and we're extra. We come in to help you. One of the things about dying at home is if you're on hospice, it's pretty simple. We come and we do all the phone calls or whatever is necessary to get the body taken to the mortuary. If somebody dies at home when they're not on hospice, the police often get involved, the coroner gets involved, the body might be picked up and taken to the coroner's office or the coroner's whatever it is, and it might be hard to get it back again. So making final arrangements is one of the things we always bring up when we put somebody on hospice, because it's better to have those arrangements made in case something happens unexpectedly than to have to worry at the last minute that somebody's going to get carted away to a county morgue and the family will have to deal with trying to get that body back. So that's the end of the presentation. This is us, Destiny Hospice and Palliative Care. My name's Holly. I'm a nurse practitioner. There's my phone number and my email down at the bottom of the slide. There's both of our office numbers and our fax number. So if you have any questions, if you'd like a presentation on a specific subject, let me know, and I can certainly prepare that. If you want me in person, I can do in person. If you want another recording, we can do it that way. So thank you for having us, and I appreciate your time, and have a good rest of your day.